Hi, good afternoon, everyone. Okay, we're going to get this session started. We're very, very grateful that you came to this session at the end of such a long day. I'm sure it'll be very exciting. My name's Debbie Layton. I'm the outgoing Education Committee Chair, and I welcome you to this session. Jacqueline?
So we are going to get started and try to keep to time here. So we will invite our first speaker, Nana Ansa, to kick us off.
Good evening, and I'm very happy to be here. I'll be telling you about healthcare workers' experiences reporting adverse events following immunization in Ghana. We don't have anything to disclose. So this picture shows the president of Ghana receiving the first shot of the COVID-19 vaccine, just to assure the Ghanaian public that it was safe and it was all right to receive it. Because of a lot of vaccine hesitancy related to issues of vaccine safety, people are very apprehensive taking new vaccines in Ghana. That is why he had to do this. And this associated with very low reporting of adverse events following immunization. And adverse events following immunization are only captured using passive monitoring. And this is also related to the poor pharmacovigilance infrastructure. So this study was conducted to look at the capacity for data collection systems and the flow of information for events associated with vaccination. The figure just shows the flow from the vaccine recipients or caregivers to the health workers, and then a focal person at the facility who also transmits the information to the district. It goes to the region before it goes to the Ghana Food and Drugs Authority, which is the National Pharmacovigilance Authority, and the National EPI, the program that oversees vaccinations in Ghana. So this was a cross-sectional quantitative study which took place in the areas that are highlighted, 5 regions of northern Ghana, which happen to be the least, the lowest resourced parts of the country. We developed a structured questionnaire and piloted it in some facilities before we rolled it out. We selected about 25 districts out of the 53, and all levels of health facilities were involved. The primary facility, which is known as the CHIPS compound, is within 5 kilometers of every house in a particular settlement, and the health centers, and then the hospital, the district hospital, a regional hospital, and a tertiary facility. And both vaccinators and prescribers were interviewed of all levels, from doctors to healthcare assistants. So about 851 participants were interviewed, with 51.7% of them male. About 60% fell between the ages 30 to 39. And about 70% had practiced for less than 5 years. A third of them were nurses. So these are some of the gaps that we saw. We realized that only 2% of these healthcare workers were aware that they could report AFIs online, even though it had been rolled out by the Ghana Food and Drugs Authority. And about half of them said their facilities had guidelines on reporting AFIs. And of those surveyed, only 25% said they had encountered an AFI within the past year. And out of these, only half of them reported. Of those who reported, more than 2/3 had no feedback on their reports from the Food and Drugs Authority. The primary facilities, which are the CHIPS compounds within 5 kilometers, had the most training, and the private facilities had the least. And when we did composite scoring of knowledge of AEFIs, 40% of the healthcare workers had a good knowledge of AEFIs. So some of the factors that affected AEFI reporting, according to them, the highest factor was that reporting forms are unavailable in their facilities. And then they also said that heavy workload and lack of time prevented them from reporting AEFIs. And it's also interesting to note that a third said that they were ignorant of how to report and where they could obtain the form. And interestingly, females were less likely to report AEFIs than males from those that we surveyed. And those who were between 30 and 39 and 40 to 49 were also more likely to report than those who were between 20 and 29 years of age. And we also realized that training and profession influence the knowledge level. So these are we can see that those who had the level of knowledge training had an impact on reporting and the knowledge level. And then physician assistants compared to healthcare work assistants were more likely to report. So it was significant. Yeah. Okay, so the way forward, we thought that it is important to have regular targeted training of health workers. The area that we surveyed has very few doctors and also very few physician assistants. And it has more of the healthcare assistants and the community health workers. So they need a lot of training. And then the health facilities also need to have guidelines and processes displayed and well established. And the National Pharmacovigilance Authority, we realized that according to the health workers, they are demotivated when they report and then they don't receive feedback from the National Pharmacovigilance Authority. So this is an area that also needs to be addressed. And as we saw, online reporting, the knowledge about online reporting was very, very low. And we thought that since in Ghana, a lot of people have mobile phones and now use their internet, especially the health workers. So if online reporting is promoted, it may increase the level of reporting. And then in Ghana, we also have our data collection systems are very poor. It is difficult to get data. Data is mostly paper-based and it gets torn, it gets missing. And because of this, we need to improve data collection and also probably consider using electronic databases. We have a national health insurance scheme, which is quite broad, but the data is not readily accessible to researchers. So possibly this could also be considered. And I guess Ghana is not different from other African countries. Maybe we need more post-marketing surveillance studies to boost safety information about vaccines, and that is going to possibly increase the uptake of vaccines and reduce vaccine hesitancy in our countries. Thank you.
Thank you, Nana. We invite the audience to come up to the microphone to ask questions. Okay, and maybe as people are thinking about questions, I was wondering if there's any reason why the females are less likely to report the AEFIs than the males.
For now, we don't know of any reasons, possibly the heavy workload and lack of time. we could attribute it to that, but we did not ask them why.
And do you have a question? Yeah. So why do you think the AFIs aren't reported as often in Ghana than in other places?
Yeah, I think Ghana focuses more on service delivery. We have so many infectious diseases and so few healthcare workers that they feel overwhelmed, and it has to do with the focus. Yeah. So if the focus changes, if we realize that it's more important, it's very important to report AEFIs, possibly there could be an increase. And because of the level of literacy to people would not tend not to report directly through the online system and would rather go to the healthcare workers. And then also sometimes when the prescribers also don't ask about the history of vaccination most of the time. So the vaccinators are probably more likely to report AEFIs compared to the prescribers.
A question?
Hi, Bennett Levitin from Janssen. So you mentioned people have cell phones. Do they have generally data access or just phone access?
They have data access, but would be unwilling to use the access to report. That's why the recommendation is if the telcos make online reporting free, it would encourage more people to report.
It would seem you may even need a push system where instead of asking people to voluntarily report, a system sort of seeks out and requests information of the physicians or nurses.
Okay.
You have a tough problem.
Thank you.
Okay, just sticking to time, are we a few minutes? We've been told we have to stick to time, so we can't start early, but if the next speaker would like to come up and get the slides ready. Priya Darshana. Priya, thank you so much. I was going to make a right pig's ear of that one. I'm so sorry.
No worries. I'm okay.
know it's a little awkward, but we were really asked to, we got an email right before this saying, make sure you stay right on the time.
Hi, everyone. I'm Priyadarshini Dharia. I'm a physician and a trained epidemiologist focusing on the post-marketing safety of vaccines at Moderna. Today, I will be presenting the evaluation or the concordance of signal evaluation using the spontaneously reported data as very nicely explained by Nana, and the analysis of the US claims database in a retrospective cohort study setting or the traditional cohort study setting. To disclose, I am a full-time Moderna employee and I do hold stocks in the company. And these are the disclosures of the other co-authors from Moderna and Adion. This is the forward-looking statement from Moderna. Oh, okay. Sorry. I don't know why. Right, let's close and start again. Stuck.
Nope.
It was the first one.
That one. Yeah.
So US FDA granted the emergency use authorization for Spikevax in December 2020. As of May 2023, 1.6 billion doses of Spikevax, original and bivalent, had been distributed globally across 91 countries for adults and children. Moderna captures spontaneously reported adverse events in the global safety database. And this database is routinely analyzed to assess the adverse events following exposure to Spikevax. However, this data is not the best one to assess or evaluate or estimate the incidence of adverse events due to the limitations of data and particularly due to the lack of precise denominator. However, during COVID, the situation was slightly different, where we did have a good vaccine exposure data because initially all vaccines were administered through vaccine campaigns by the government, and the health authorities updated the vaccine exposure data regularly. During the past 2 years, we also conducted a post-approval safety study to assess the safety of Spikevax using the US claims database from Health Verity. In this study, specifically, we are comparing the signal evaluation results from the spontaneously reported data and the signal evaluation results using the traditional retrospective cohort study design. So what is Global Safety Database? All the adverse events reported across all the countries from consumers, from healthcare professionals, from the regulatory authorities are captured in this database. We include non-serious adverse events, serious adverse drug reactions, and the pregnancy reports. Serious adverse events include adverse events that require hospitalization, prolongation of hospitalization, can be life-threatening, or a result in disability and death. Although this database is large, particularly with COVID, it has its own limitations, particularly underreporting, the reasons some of which Ansa touched upon. Then sometimes, on the other hand, it is simulated reporting because social media, news articles actually pick the adverse events and then they are reported more. There's also lack of context around the adverse event with lack of medical history, lack of concomitant medications, comorbidities for this data. The health authorities, as they updated the vaccine exposure, we had a good estimation of what percent of the vaccines were administered across the globe. So of the 1.6 billion doses, we estimated that 55% of these doses were administered resulting in around 984 million doses. Using a 21-day risk window after each vaccination, we estimated around 56 million person years. For adverse events such as myocarditis, where the etiologically relevant window was known, we did do the analysis using alternative windows. Using the calculated person time, we conducted observed to expected analysis from the using the spontaneously reported data. For this, we calculated the observed reporting rate from using the observed number of cases from the global safety database and the calculated person time, and the expected background incidence rate from the published literature, peer-reviewed journal, and Access Had a Good program, where they actually reported age-gender stratified background incidence rate in the pre-COVID era. So those were the two main places where we used the background incidence rate. Rate ratio was calculated simply by dividing the observed reporting rate to the expected background incidence, along with its 95% confidence interval. We determined the threshold of the increased risk or the signal evaluation being positive if the lower bound of 95% confidence interval was greater than 1. Also conducted few sensitivity analysis, particularly due to if there were multiple background incidence rate and to understand the impact of underreporting. The results of observed to expected analysis was then compared to the signal evaluation results from a retrospective cohort study design using the US claims database. This had 3 main cohorts: the pre-COVID cohort, which was before the COVID-19 infection, the active COVID-19 cohort, which was between the COVID-19 infection and before the authorization of COVID-19 vaccines. These two were the background cohorts, and the exposure cohort, which was post-EUA, basically after the exposure, after the authorization of COVID-19 vaccine. Each adverse event was assessed using 3 stages. The signal detection, in which the crude incidence rate of the exposed was compared to the background incidence rate. If the threshold was met for this, the signal refinement of the adverse event was conducted using observed to expected analysis. If the observed to expected analysis results met the threshold, then the risk estimation was conducted in the signal evaluation stage using a self-controlled risk interval analysis. This method is very routinely used in vaccine safety studies. Here we captured risk window after each dose of Spikevax, 28 days after each dose of Spikevax, and captured control window as 42 days after the end of risk window. To exclude the duplication of the claims, we required a 7-day minimum time period between the 2 doses of Spikevax. Conditional Poisson regression was used to calculate the event rate ratio for AESI after the Spikevax. So at the time of analysis, we had conducted around 50 plus AESI observed to expected analysis using the spontaneously reported data. And as per protocol, 44 AESIs were, the signal evaluation of 44 AESI was done using the US claims database. Of these, 32 were common using both the methods. Myocarditis and pericarditis, the 2 known adverse events of Spikevax, had consistent results using both the methods, particularly when we look at males, young males within 7-day risk window after dose 2. Of the 32, 30 had no association. We did not have any evidence of association with Spikevax. 29 had consistent interpretation throughout. For single organ cutaneous vasculitis, although the overall results were consistent, when we looked at those three specific analysis, the event rate ratio was slightly higher in males. In global safety database, we did not see that. But this result should be interpreted with caution for two main reasons. One is we had a very small number, and two, there was multiple testing done in the study. To conclude, any global safety database and Moderna global safety database is a rich source for screening of adverse events, particularly rare events. However, analyzing this data is extremely challenging due to a number of limitations, as mentioned before, that is underreporting, simulated reporting, lack of context of the adverse events, and definitely lack of precise denominators. With COVID, we had better information about the vaccine exposure. So we had good estimates of adverse event reporting rate. Although with other vaccines, the vaccine exposure might not be that good, there should be a first step in the continuing of the signal evaluation in vaccines. Thank you for your time.
Time for some questions from the audience.
Hi, I'm Harry Seifert from GSK, speaking only for myself, of course. Observe to expected, the bane of my existence. So I acknowledge that it's what we have to use, and I acknowledge the regulators require it. But how do we rationalize using what's essentially historical control data or historical expected data, especially when we know we're in the middle of a pandemic, and in fact, the pandemic may either increase or decrease the frequency of some of the events that we're most interested in?
That is a great question, and we do struggle with that every single day.
But do you have a great answer that we could use?
I'll try my best. So basically, for some conditions like anosmia, we did use during COVID as a background rate and not pre-COVID, because obviously we know that anosmia is associated with COVID-19. So I think over the period of time, we just have to make sure that we have to do the comparison. We have to see which is the best rate to use and then move forward. But that's a question that we try to answer every single day. Thank you.
Thanks.
One more question, thank you.
Yes, Alena Kromova, Sanofi Vaccines. So I have similar question to Harry's, and it's more about your comparison using the claims data. So why did you choose to compare to the historical background rates and not to use the self-controlled risk interval? Because unlike the pharmacovigilance data, you actually have the time when the person was unexposed, within, it's longitudinal data.
So I think I wasn't clear in my presentation. In this, the US claims database 44 ASI that we evaluated, here, when I'm presenting the results, they are the SCRI evaluation. And because we had a staged, we just had few ASI which went through the signal evaluation. So that's why the results are like the US claims database study, the results that are shown here are from the signal evaluation and not the observed to expected analysis.
And I have a second question, if you allow, very short. Why did you use 21-day risk window when we know that for events like anaphylaxis, they're pretty immediate? So I would argue that, based on the biological plausibility, your risk window has to be adjusted based on the event.
Yes, that is correct. And for the claims database, we did that. But for the observed to expected analysis, we did use alternative windows for few, like anaphylaxis and myocarditis. But for others, we kept it 21 days. VSD has provided that as 21 days. So that was that's where we started.
Thank you.
Thank you, Priya.
Thank you.
And now our next speaker is Disha Patel.
Okay, and then just presenting. Hi, everyone. I'm Disha Patel. I'm an epidemiologist at Aetion, and I'm happy to present findings from our analysis on behalf of my Aetion and Moderna colleagues. This is my disclosure. And this is the forward-looking statement for our organizations. So since the mRNA 1273 COVID-19 vaccine was granted emergency use authorization, a post-authorization safety study was conducted using administrative claims data to assess associations between mRNA 1273 and 44 potential adverse events of special interest, or ASIs. And for that safety study, the final safety report was based on using closed claims data alone. There are two main types of claims data: closed claims and open claims. Open claims, which provide contemporary data, can be beneficial in vaccine safety surveillance, where time is of the essence to make vaccine policy decisions and clinical guidelines for providers. However, the impact of supplementing closed claims with open claims is unclear, and therefore we conducted a post hoc assessment of differences in analyses that used both closed and open claims, which is the focus of this presentation today. Both claims types have their advantages and limitations. Closed claims are fully adjudicated and sourced from the insurer during periods of enrollment. A key advantage of closed claims is full observability. They provide a generally complete set of patients' medical and pharmacy encounters covered by the insurer. Limitations of using closed claims include a longer data lag, a smaller population limited to enrolled patients, and a lack of observability into patients' encounters that are not covered by the insurer. Meanwhile, open claims are non-adjudicated, sourced from providers and clearinghouses, and do not include an enrollment file. Compared to closed claims, a key advantage of open claims is having a shorter lag from the date of service, because this data is captured prior to adjudication. However, while open claims may capture a greater volume of events, they don't capture patients' encounters outside of the open claims network. And so this lack of true observability may contribute to outcome misclassification and other limitations. Before describing our different claims approaches, I'll walk you through the study design. Consistent with the original safety study, in our post-hoc analysis, patients indexed on their first observed dose of the mRNA 1273 vaccine in the HealthVerity claims database between December 11th, 2020, the first FDA emergency use authorization for COVID-19 mRNA vaccines, through August 31st, 2022, the end of the study period, applying a 6-month truncation prior to latest available data. Patients were excluded if they were missing age or sex at cohort entry or had a history of COVID-19 vaccination or the ASI prior to cohort entry. We also applied an observability requirement. In closed claims, we required patients to have continuous medical and pharmacy enrollment, allowing 60-day enrollment gaps and a 60-day extension period after the last evidence of enrollment. In open claims, given the lack of an enrollment file, we assumed observability on dates when claims occurred, allowing 60-day gaps between claims and then a 60-day extension period after the last claim was observed. For ASIs where a signal was detected, we performed a self-controlled risk interval, or SDRI analysis, as Priya previously described. So I won't go too far into that, but this is a commonly used self-control study design in vaccine safety studies, because we are able to focus only on the vaccinated cases, and it can be more efficient in some cases. So this is very helpful in situations where widespread vaccination would make it challenging to identify unvaccinated comparators. So we assessed in our dose agnostic analysis up to 3 doses of the mRNA 1273 vaccine. Patients were followed in an ASI specific risk window after each vaccine dose, with the risk window being 28 days for the ASI in this example. And then that was followed by a 42-day control window. Patients were followed until either the end of the control window or a censoring event occurred, and we used conditional Poisson regression to calculate an ASI event rate ratio, or ERR. We applied additional cohort exclusions to the vaccinated cohort prior to conducting SCRI. Patients were followed until the end of the SCRI control window or other censoring criteria as shown on this slide. Consistent with our cohort definition, we required observability through follow-up, and that was based on enrollment records and closed claims or on claims activity and open claims. So we assessed 3 different approaches for using claims data to define our study variables. The first was a closed claims approach. We defined patients as observable based on medical and pharmacy enrollment records, allowing for 60-day gaps and extensions. We limited inclusions and exclusions, our vaccine exposure, our outcome, and then our censoring criteria to closed claims. By limiting to closed claims, we were able to minimize potential exposure and outcome misclassification. Our second approach partially supplemented closed claims with open claims. We applied the same observability requirement as in the first closed claims approach, and most of our study variables were limited with to closed claims, except for a few exceptions where we used both claims types. These were the prior COVID vaccination washout, our mRNA 1273 vaccine exposure, and then our censoring on a 4th mRNA 1273 dose or another COVID vaccination. So here we were able to maintain observability while using the open claims to capture additional vaccine exposures that were not billed to insurers. Our third approach allowed us to observe the impact of using closed and open claims to capture all study variables. We modified the observability requirement so that in the absence of an enrollment file, we assumed observability based on claims activity. And again, we allowed 60-day gaps and extensions and followed patients until 60 days after either the last enrollment record or last claim was observed. So, as you can see here, compared to using closed claims alone, we saw an increase in the sample size because open claims allowed that additional capture of vaccine events. And again, in the first 2 approaches, observability was based on enrollment records and closed claims. And then you see a substantially larger increase in the vaccinated cohort once we fully supplement with open claims. And again, that's because we have allowed for claims activity to be used to capture a larger number of patients. So now I'll use 2 ASIs as examples to describe how these claims approaches impacted our analysis, and that will be chilblain-like lesions and anosmia and ageusia. So findings were consistent for the STRI cohorts of vaccinated chilblain-like lesions cases. We see here that when you partially supplement with open claims, we have a slightly greater number of vaccinated cases in both the SCRI windows, and then fully supplementing, we see substantially more vaccinated cases. Here we see similar findings for anosmia and ageusia as we supplemented with open claims data. So results of the STRI analysis also differed by claims approach. Using closed claims only, we did not observe an association between our exposure and chilblain-like lesions, but then when we partially supplemented with open claims, we did see a slight improvement in precision and consistent ERRs. When we fully supplemented with open claims and we assumed observability using claims activity, we saw an even greater improvement in precision, and then ERRs were further from the null among adults overall and within our age and sex subgroups. So here it was a little different. So we did see an improvement in precision as we supplemented with open claims, but varying results for the ERRs as we used full supplementation with open claims. And that differed by age group. So there's a couple of limitations I'd like to note. First, we use claims algorithms to estimate incidence of potential ASIs, and these algorithms can vary in their sensitivity and specificity. Secondly, administrative claims are limited to healthcare encounters billed for reimbursement, and then open claims are further limited by a lack of true observability. So based on our analysis, we found that the partial approach balanced the strengths and limitations of using open claims. We improved sample size and precision. At the same time, we're able to ensure true observability by allowing patients to have their follow-up for the outcome using both closed and open claims, but then using only closed claims to ensure that there was true observability through enrollment files. And so we recommend that, the utility of open claims may differ by research question, and you really do need to weigh the benefits and limitations of using open claims in your particular study. Thank you.
Hello, Bradley Layton from RTI Health Solutions. Thanks so much. I think you mentioned very briefly, and I'm sorry if I missed it, that you ensured observability in the open claims using claims activity during that time. Can you describe a bit about how you operationalized that?
Sure. So we performed a lot of different exploratory data analyses to figure out what the optimal definition would be to define observability using open claims. So in the closed claims approach, we already had enrollment files to work with. And then in open claims, we needed to basically conduct, and this is something I recommend for any study that you have, and it really depends on your particular research question. For us, we use that 60-day gap, but we explored various gaps between claims to really determine what the optimal approach was there compared to, looking at those same patients in the closed claims data as well.
Mm-hmm. Okay, thank you.
I've got a question. Sorry, but just very quickly, Kevin. Again, I may have missed it. In terms of the outcomes, so in open claims, they're less robust. They haven't been adjudicated or assessed by. Is that right?
That's correct.
Yeah.
Yeah. So this is prior to adjudication, and that's why there's a shorter data lag from the date of service when you're being able to see the open claims. So they can be very useful if you're looking for speed and data collection, which is common in safety studies and vaccine effectiveness studies. But you do have to consider, that it is not adjudicated. So there are some limitations to using that. And one of them is the lack of true observability and having to make some sort of proxy for observability.
Okay, thanks.
Kevin Haynes, Johnson & Johnson. Really great presentation, great stuff. Question about it looked like you used all available data to exclude people if they had an event. So if I had anaphylaxis 3 years ago, I was out of the anaphylaxis cohort, similar to the chill bands and the other stuff. Do I have that correct?
That's a great question. In this post-hoc analysis, that is what we did in the larger safety study that was performed. We used different
follow-up question. Did that change when you had the open claims? Like, could the open claims also be used to get me the heck out if I had an event in some random open claims?
Yeah, that's a great question. Yeah, so we did use open claims for that. For really the enrollment criteria or the proxy for enrollment is where we restricted to the enrollment files.
Any other questions? Thank you. I'd like to invite our next speaker, Dania. Yeah, thank you.
Hello, everyone. My name is Dinah Esposito, and I'm the Executive Director for Global Safety Epidemiology at Moderna. And on behalf of my co-authors, I'm grateful for the opportunity to present this analysis of myocarditis risk following primary series and booster doses of Spikevax in the U.S. administrative database. Here are our disclosures and acknowledgements. Of note, the study was funded by Moderna as part of a post-authorization safety study commitment and was conducted by Adion. Myocarditis refers to inflammation of the myocardium, and while it may resolve spontaneously, it may also be associated with adverse outcomes such as heart failure, dilated cardiomyopathy, and arrhythmias. The most common etiology is infection, including infection with SARS-CoV-2, and young men are recognized to be at higher risk. Although cases are rare, myocarditis is an identified important risk associated with vaccines targeting SARS-CoV-2, including Spikevax or mRNA-1273. In this study, we sought to evaluate the risk of myocarditis following doses 1, 2, and 3 of Moderna's vaccine targeting SARS-CoV-2 as used in routine clinical practice. An overview of the U.S. post-authorization study in which these analyses were conducted has been described by Disha Patel early in this session, as well as by Dr. Priyadarshini Daria. However, in brief, the study used a staged approach in which incidence of 44 outcomes, including myocarditis, was estimated in a historical time period prior to COVID, as well as during an active COVID period prior to the introduction of vaccines targeting SARS-CoV-2 in the US. And then rates were also assessed after vaccination using data from 2020 through 2022 and August 31st specifically. Administrative claims from Health Verity for individuals with closed claims enrollment files were included, and again, data extended through August 31st. A diagram of study entry criteria for the vaccinated cohort in the signal detection phase is shown here. And so of note, separately for adults and for children, vaccine recipients were identified among individuals with at least 365 days of prior health plan enrollment, no prior diagnosis of myocarditis for this outcome specifically, and of course, known age. We looked at subgroups defined by age, sex, age by sex, and immunocompromising conditions at baseline. And in total, this identified 6.8 million vaccinated individuals who were followed to assess these safety outcomes. These 6.8 million vaccinated individuals, again, were compared in the detection phase to those historical populations defined by availability in the Health Verity data set with prior enrollment. In the self-controlled risk interval analysis for myocarditis, the primary analysis focused on a 7-day risk window and a 42-day control period. Individuals had to have a myocarditis event following vaccination in either that risk or control period, as well as at least 1 day of medical and pharmacy enrollment in both periods. And they could not, of course, have been censored prior to contribution to the control period based on criteria such as end of the enrollment file or vaccination with another product targeting SARS-CoV-2. Stratification of self-controlled risk interval analyses was performed by age, sex, and age by sex. And analyses were performed using all doses and then separately for dose 1, dose 2, and dose 3. We looked at case characteristics of myocarditis, as well as healthcare utilization in the risk and control periods, as well as overall for any event, and estimated event rate ratios, again, comparing in the primary analysis, the 7 and 42-day risk and control windows respectively, using conditional Poisson regression with sensitivity analyses considering alternate risk windows, and heterologous vaccination schedules. In this table, you can see demographic and baseline comorbidities in the final cohort, so all adult mRNA-1273 recipients, as well as in individuals who contributed to the dose-agnostic SCRI analysis of myocarditis. So in blue, you can see the 6.8 million adult vaccine recipients who had a median age of 50 years, of around 56% were male, a slight majority were commercially insured, and rates of cardiovascular disease were relatively high at around nearly 38%. Looking at the cases that accrued in the risk and control periods respectively, so 74 cases in the risk window and 202 cases in the 42-day control window, you can see that cases in the risk window were younger, were more often male, had slightly lower rates of prior cardiovascular disease. Cases in the control window more closely mirrored the general population of vaccine recipients in terms of demographic characteristics. However, they had higher rates of comorbidities at baseline. Here we can see healthcare utilization in individuals with myocarditis occurring after dose 2, where dose 2 is particularly in focus, given the recognition of increased risk associated with that dose in other studies. Among the 4.7 million, nearly 4.8 million dose 2 vaccine recipients who were included in the study, we saw a total of 736 myocarditis cases at any time. And as you can see, a majority of those cases actually occurred after the end of the 42-day risk or control window that is used in SCRI analyses. When we look in the middle and last column at the risk window and control period cases, we can see that the time from vaccine dose to myocarditis in the 7-day risk window was about 3 days, and hospitalizations had a median duration of 2 nights, which was slightly shorter than the control period and overall case hospitalization durations. In this figure, you can see forest plots demonstrating the SCRI analysis results for myocarditis in adults stratified by age. In the first bar, you can see overall for any dose, all doses. In the middle, we see dose 1 among the 6.8 million exposed, dose 2, and last dose 3. Overall, the risk of myocarditis in individuals over 18 was elevated, and this is predominantly driven, if you look at dose 2, by an increased risk that was most marked in younger adults, with the highest risk ratio of 8.47 in adults 18 to 29 years of age. In dose 3, you can see that although this is not statistically significant, it is consistent with the same pattern of an elevated rate ratio, with a similar pattern of a higher elevation in younger adults as compared to other age groups. Of note, however, although there were 1.8 million individuals exposed to dose 3 in this cohort, the SCRI analysis included only 9 risk window and 28 control window cases, and all strata by age included fewer than 10 cases. In this figure, you can see the same results. However, now they have been stratified by gender as well. So in the top, we see rates stratified by age for males, and in the bottom for females. The pattern is largely consistent with what you just saw in the overall analysis, with a stronger increase in young men, and particularly the highest increase in males 18 to 29 years of age after dose 2, at an event rate ratio of 9.5. Similar elevation is seen in young women, albeit less marked. And again, in dose 3, we see an elevation that is lower than what we see in dose 2, however, still, albeit for young men, not technically statistically significant, markedly elevated. In terms of limitations of this analysis, the myocarditis diagnosis here is based on ICD-10 codes and could not be confirmed by medical record review in this analysis, so is subject to misclassification. In terms of what that I think is likely to mean, I think the myocarditis diagnosis, if it is a non-differential misclassification, would be expected to produce an estimate that would be farther or closer to the null. However, in this particular case where we know that there has been increased recognition of myocarditis, of course, after vaccination, we might expect the possibility of differential misclassification as well, in which cases that are more proximate to vaccination may be more often detected. Also of note, we did have low power in the dose 3 analysis, despite that very large size, given just how rare this event actually has been. However, we do believe that the results are consistent with an increased risk. And finally, due to the limitations of coding within this data environment, we're not actually able to distinguish for dose 3, whether we're looking at a 50 microgram booster dose of mRNA-1273 or a 100 microgram primary series dose, which is actually given to immunocompromised adults. In conclusion, results of this study were largely consistent with the known safety profile of mRNA-1273, with an increase in the risk of myocarditis, especially in young adults, and stronger associations in young men and after dose 2. Additional characterization of the risk of myocarditis after booster doses is going to require additional large population-based studies, including those that are ongoing, given the low event rate that has been observed. Thank you, and I'll be happy to take your questions.
Actually, I have a quick question. I might have missed at the beginning. For dose 1, 2, and 3, these are all Moderna doses, so everyone had to be on the same type of vaccine?
Yes, this is entirely Spikevax exposed. So people were actually censored from the study if they received something that was other than a Moderna dose in the primary analysis.
Okay, so if you were dose 2, you would have had a primary.
Correct.
Yeah.
So you would have had a dose and that dose would have been observable.
Hi, I'm back. This may be a
Welcome
regular.
back.
I'm back. This may be a regulatory question rather than a scientific question, but if we know that the highest risk, the group at highest risk is what I'll call boys, it's from 12 to 25. Why did this study start at 18? Was there a complementary study or?
Absolutely. So the study actually didn't start at 18. The study included individuals of all ages. However, we presented the adult cohort. We did separate analyses of the pediatric cohort that were just too small, given that Spikevax was licensed in the US much later than the BioNTech or the Pfizer-BioNTech vaccine. We simply didn't have the exposure to reasonably characterize that here.
No, it's all right. I was going to ask you a question, but it's regulatory and you won't be able to answer it.
I
And
kind of want to know.
And the FDA was satisfied with that, or will this be continuing?
Oh, there are additional studies that are continuing.
So I had a question I saw recently, and I don't remember where, maybe somebody in the audience knows, the recent VAERS Sentinel analysis that looked at it geographically at adverse reporting. Jacqueline, are you smiling? And they found a really interesting correlation in terms of timing of the adverse reporting in the system where everybody can do it. I was just wondering if you would, just trying to get at that misclassification or potential ICD-10, if you found a similar geographic sort of signal baseline in the healthcare in the claims data that maybe correlated with the VAERS analysis.
That's interesting. I think that would be a great direction for us to pursue. We have not looked at these data geographically, in part because given the nature of the database, we're limited in terms of our resolution. But it's a great note.
Hi, Bradley again. Just a very detailed question about the SCRI analysis. So you had 3 doses, each one of which potentially had its own control window, and depending on the timing of the 3rd dose, they were potentially of different lengths. So you did one overall, considering just a case in any risk window or a case in any control window. And then for your dose-specific ones, did you restrict to just the risk period and the control period for that dose, or was it the risk period for that dose compared with all of the control periods?
So for the dose specific analysis, we have a risk period and a control period. However, if we have, for example, as one might expect with the dosing schedule, less than 42 days between the end of the risk window and the next dose, we continue over and continue to add time to the control period after the next risk period has been completed.
Okay, so in your dose 1 analysis, there's a 28-day gap in the middle of the control period where dose 2 occurred. Correct. Is that correct? All right. Okay, thanks.
Got one small question. The risk window, 7 days, I noticed that you've kind of used a blanket including day 0.
So in the main analysis, we actually looked at day 1 through 7, so not including day 0. We do have, actually, they weren't presented in the interest of time, but we do have sensitivity analyses where we varied that. So including a 21-day and also looking at cases that occurred on day 0 in terms of their characteristics and so on.
And how did that look?
I mean, I think the message in terms of the safety message stays the same as you would, I think, would expect as you have a less specific window, the ERRs attenuate.
Okay. Maybe just one more question. So the previous presentation talked about open and closed claims, and this one was just closed claims, is that
Yes.
correct? Did you do any sensitivity analyses to also look at open claims?
Sure. So part of the way the study was designed is this is a study that has actually been going on for some time. And the interim reports included both open and closed claims for exactly the reasons that Disha described, of needing to have sort of more rapid accrual of information that could then be further vetted. It was pre-specified that the final report of the study would include closed claims given the observability question that we've discussed. So this is looking at the final results. I think perhaps the question behind the question is the power resolved when we look at open claims? And unfortunately, at least as of the last interim report where we looked at the open claims data, it is not. We still did not have really enough to kind of clarify. We still have that directional increase in dose 3 without a statistical association.
Thank you. Our next presenter is Patricia Lloyd.
Right. Good afternoon, everyone. Thank you for hanging in there. I know it's close to a dinner time, so great job. My name is Patricia Lloyd, and I'm a health statistician with the U.S. Food and Drug Administration and the Center for Biologics Evaluation and Research, or CBER. So on behalf of my co-authors, we appreciate the opportunity to present findings from 2 self-controlled studies of COVID-19 vaccine. So before we begin, the views in this presentation are solely of the authors and not of the U.S. Food and Drug Administration. So here's a brief roadmap of this presentation, beginning with an overview of the CBER, or the FDA CBER Active Surveillance Program, and diving into the study methods, results, discussion, and conclusion. So the Biologics Effectiveness, Safety BEST system is the CBER Active Surveillance Program for biologic products, including vaccines, which was built on prior systems such as Sentinel PRISM, and is a robust and flexible system which was prepared to quickly respond to pandemic needs. The vision of the CBER Active Surveillance Program is to create and utilize an effective national post-market surveillance system for CBER-regulated products to provide data for evidence-based regulatory decisions. The FDA CBER Active Surveillance Program conducts surveillance of biologics through multiple interdisciplinary partnerships, as illustrated here. For safety surveillance of COVID-19 vaccines, particularly for potential rare adverse events, we collaborate with federal partners and we work with large nationwide health plans. COVID-19 vaccine safety surveillance has 2 main components, including signal detection and signal evaluation. Signal detection includes near real-time surveillance to rapidly detect signals, yet these are often crude analyses. If signals are identified, then we conduct fully adjusted epidemiologic studies to evaluate these signals. What we are describing here in this presentation are the signal evaluation studies for the COVID-19 primary series and monovalent booster vaccines in adults aged 65 years and older. So here is a brief summary of the methods. The 2 vaccines in the study were BNT162b2 and mRNA-1273, which I will refer to as the Pfizer-BioNTech and Moderna COVID-19 vaccines moving forward. The study period for the primary series study aligned with the authorization of the first COVID-19 vaccine emergency use authorization through spring of 2021, and the study period for the booster study aligned with the authorization of the monovalent booster through spring of 2022. Both studies included CMS beneficiaries aged 65 years and older who received doses of the mRNA COVID-19 vaccine and an incident adverse event listed below. Both studies employed a self-controlled case series design to evaluate acute myocardial infarction, AMI, pulmonary embolism, PE, and immune thrombocytopenia, ITP. The same self-controlled case series design was used to evaluate disseminated intravascular coagulation, DIC, in the primary series, while Bell's palsy, BP, and myocarditis pericarditis were monitored only in the booster study. The self-controlled case series design for the primary series included individuals who received a homologous primary series of the vaccines, so Pfizer-BioNTech and Moderna COVID-19 vaccines. The post-vaccination risk interval was defined as the period beginning on day 1 and extending to day 28 following the second vaccine dose, and the post-vaccination control interval was through day 90. Similarly, the self-controlled case series design for the booster vaccination study included a post-vaccination risk interval on day 1 to day 28 and a post-vaccination control interval through day 90. So for both studies, we calculated incidence rate ratios and attributable risk. We also estimated the positive predictive value, or PPV, through medical record review, and conducted quantitative bias analyses as well as seasonality and PPV adjustments. Study-specific analyses were also conducted, and those are listed below. So now to some descriptive results. So in this table, we present the number of cases by adverse event in each study by vaccine brand. So in the left column, we have the list of adverse events that we evaluated. And moving to the right, we have the total number of cases by study and vaccine brand as well. So the number of events in the primary series study are generally higher following the primary series vaccination with Pfizer BioNTech than Moderna COVID-19 vaccine. However, the number of events are relatively similar between the two vaccine brands following the booster dose. And it is worth noting that the primary series study and the booster study, they were conducted separately in different time periods during the pandemic. So the primary series study was conducted first and earlier in the pandemic era in 2021, when a smaller proportion of the elderly population had received the primary series vaccinations or vaccines. The booster study was conducted later in the pandemic in 2022, when a larger proportion of the elderly population had received a monovalent booster dose. Therefore, the booster study generally has a larger population than the primary series study, and subsequently a larger number of events for most of the events. So now for our inferential results. I want to orient you first to the format of the next 6 slides, which present the forest plots for each of the adverse events by vaccine brand for the 2 studies where applicable. So you will notice the positive predictive values for the outcomes in an orange box in the upper left. The incidence rate ratios and the 95% confidence intervals are also presented for each analyses. Moving down, we get to each of these sensitivity analyses that we also had looked at. Enclosed in a box are the analyses that we want to highlight, and those that have the highest level of adjustment possible, where a red box indicates a statistically significant increase in the risk of the adverse event following vaccination, and a blue box indicating a statistically significant decrease in the risk of the adverse event following vaccination. So just to note, for AMI, we observed a marginally statistically significant increase in AMI following Pfizer BioNTech booster dose, but not following the primary series. And I will just note that in the primary series, you could see there are some incidence rate ratios that that were above 1, and the confidence intervals were also above 1. Yet when we did our most fully adjusted analyses, you can see those estimates had been attenuated. So we're really focusing on here the results after the booster dose. But as I mentioned, these were marginally statistically significant. For pulmonary embolism, we observed a statistically significant increase following the Pfizer BioNTech primary series, and a statistically significant decrease in the risk following booster doses of both Pfizer BioNTech and Moderna COVID-19 vaccines. We observed no difference in the risk of ITP following vaccination with primary series and booster doses of both Pfizer BioNTech and Moderna COVID-19 vaccines. And there was no difference in the risk of DIC following primary series vaccination for either vaccine brand that we observed. Following booster vaccination with both Pfizer BioNTech and Moderna COVID-19 vaccines, we observed an elevated risk of Bell's palsy. However, when we accounted for the low PPV, the estimate was attenuated. So in red were those results, but again, when we adjusted for the low PPV, the results in purple indicate that the estimate was attenuated, and there was no significant increase in the risk of BP. And lastly, there was no difference in the risk of myocarditis pericarditis following booster vaccination for either vaccine brands. So there are several strengths in these studies, including the ability for us to control for time invariant confounding in large population-based database of adults aged 65 years and older. However, there were also some limitations. There was potential underreporting of COVID-19 vaccine administration in claims, as well as potential outcome misclassification in the claims data. There was also, we also had encountered low PPV for a number of adverse events that we monitored. There was a possibility of misclassifying the risk and control intervals, as well as potential for residual confounding. So in conclusion, neither studies identified a safety concern for acute myocardial infarction, immune thrombocytopenia, disseminated intravascular coagulation, Bell's palsy, and myocarditis pericarditis. However, there was inconsistent evidence of an elevated risk for PE after exposure to COVID-19 mRNA vaccines. I just want to thank all of our co-authors on this paper. Yes, thank you very much. Welcome to taking questions.
Kevin Haynes, J&J. Really great presentation. I was lost a little bit. Where did the PPVs come from?
Yeah, so they were, we were able to do medical review for primary series analyses and also for those studies that were, or those adverse events that were looked at in the booster study. Some of those are still ongoing.
Was it a sample of charts?
There were samples of charts.
100 charts each for each?
I would have to
outcome?
look back to.
Was it differential between the two brands? Or did you not look at differential misclassification in the PPVs?
We did not that I'm aware. We didn't look at by brand. No.
Okay. And then just one other question. So it looked like, and this is going back to the Spikevax presentation, that you had 6.1 million Moderna boosters and 612 outcomes in an over 65 population. Moderna would salivate over that because that's like a ton of data that they didn't have. Like that just seems really high, right? That 612 myoimperi cases in a booster population in an over 65 population, given the presentation that we just saw, which I know you're just having seen and haven't really digested yet. But does that seem high?
So this does seem high. And as I mentioned before, when we, the study periods were different. So we know that, there were a lot more of the, elderly population that had received the monovalent booster dose. So that's, I think, the reason why when we looked at these, while it does look high.
And are you a 1 to 7 day risk window there?
So in this study, I believe we did a 1 to 21 day.
Okay, all right, great, thanks.
Yeah, thank you.
Hi, Dinah Squizito, Moderna. First, thank you for a great presentation. I'm curious if you can elaborate a little bit on the methods you used for the PPV adjusted estimation.
Yep. So let me just quickly go back. So there were a number of different adjustments that were done. Some of them were specific to the study here. So because we knew that some of the outcomes may have been misclassified in claims data, what we did was we incorporated, and I don't have the details so much, but with the PPV, we estimated how many we would have likely have seen based on the estimate that we had calculated. So I can give you some more details after. I can send you our methods if you'd like.
Thank you. I'd love that.
Hitachi Urishihara from Keio University at Tokyo. Thank you for your good presentation. Just I would like to ask the setting of control period. So you didn't examine the control period before the vaccination.
Correct. It was just post-vaccination.
Why?
Well, I think we did
because this is a claim data. You can get the outcome data from the before the vaccination.
I believe that we had looked at some pre-vaccination control intervals, but our primary analysis was the post-vaccination control intervals. And so I don't think that there were any major differences in results that we report on, but yeah, so it just wasn't included because it wasn't our primary. We felt that the primary was the post-vaccination.
Okay, thank you.
Thank you for the question. Great, thank you.
Yeah. So we come to our last presentation. Going to invite Hee Hwan Won to present on her final abstract.
Okay, thank you for introduction. I'm Hee Hyun Won, a PhD student at Ewha Women's University in Korea. Thank you for being here. I'm presenting the research titled Safety of Concomitant Administration of 23-valent polysaccharide pneumococcal vaccine and influenza vaccine among the elderly. I disclose the following facts. Influenza and pneumococcal disease are associated with considerable morbidity and mortality in the elderly. Approximately 1.6 million high-risk individuals die from pneumococcal disease each year. In many countries, it is recommended for those aged over 60 to receive the seasonal influenza vaccine and the pneumococcal conjugate vaccine. A single dose PPSV23 and an annual inactivated influenza vaccine are included in the National Immunization Program for the elderly in Korea. Concomitant vaccination refers to the administration of 2 or more vaccines on the very same day. PPSV23 and the influenza vaccine can be given simultaneously. Vaccines may pose some safety concerns. However, when it comes to the safety of concomitant vaccination, there is very limited information available from post-marketing data. The aim of this study is to compare the safety of co-administering PPSV23 and the influenza vaccine concomitantly versus in sequential injections within the Korean elderly population. This slide provides a brief overview of the research method. The study is a retrospective matched cohort study that uses linked database to evaluate the safety of concomitant vaccination and the incidence of 16 events in individuals aged 65 and over. 2 national databases, the Immunization Registry and the claims data, which were linked by the National Health Insurance Service, were analyzed. The vaccination registry data includes records of individuals over 65 years of age who received at least 1 dose of PPSV23. The claims data contains medical records of those registered in the vaccination registry. We used a retrospective matched cohort design for patients who were either concomitantly or sequentially vaccinated with PPSV23 and influenza vaccine. Concomitant vaccination group was defined as individuals who received both PPSV23 and influenza vaccine on the same day, whereas sequential vaccination group included individuals who received influenza vaccine during the period from 1 year to 30 days prior to the date of PPSV23 vaccination. For the selection and the definition of study groups, we used previous studies as a reference. The cohort index date was defined as the day when PPSV23 was administered. Individuals aged over 65 who received their first dose of PPSV23 between 2016 to 2020 were included, and there are 3 exclusion criteria as follows. To assess the safety of concomitant vaccination, we separately examine adverse events associated with the pneumococcal vaccine and influenza vaccine and select specific events of concern. We compiled an event list based on the adverse events reported to VAERS and CARES after vaccination, as well as from previous studies that conducted signal detection. Clinically mild adverse events were excluded from our list of over 50 adverse events, such as fever and dizziness, as well as those difficult to identify from the claim data. Based on their clinical significance and severity, we further refined the list of events of interest. Ultimately, we came down to 14 events related to safety and 2 events for effectiveness. The table shows the definition of the ICD-10 code and the periods to exclude previous history and for follow-up. The table shows the definition of the ICD-10 code and the periods to exclude previous history and for follow-up. Patients were then followed from index date until the earliest occurrence of adverse events, death, and vaccination, or the end of the follow period. For each event, we created codes excluding prior history. We calculated the incidence rates per 1,000 person years, employed 1 to 4 propensity score matching, and utilized conditional Poisson regression to estimate the incidence rate ratio. Additionally, we performed a subgroup analysis by gender. Next is the study results. The initial cohort of this study consists of about 88,000 patients who received concomitant vaccination and about 1.2 million patients who received sequential vaccination. In the initial cohort concerning the administration month of the concomitant vaccination group, October was the most common, while in the sequential vaccination group, July stood out as the most frequent administration month. For each event, we created matched codes, and this table represents the matched code for allergy reaction. This table shows the total number of patients and the number of incidents and incidence rates per 1,000 person years. The incidence rates differ by its event. In the initial analysis, concomitant vaccination reduced the risk of allergy reactions, neuritis, and pneumonia, yet increased the risk of paralysis and death. While the overall risk persisted, they declined after adjustment, except for the risk associated with paralysis, which remained significant even after the adjustment. The paralysis event was further analyzed by dividing it into subcategories, including hemiplegia, paraplegia, and tetraplegia. Among the subcategories, only paraplegia showed a statistically significant increase in ILR, but the number of cases was notably limited. In the subgroup analysis by gender, pneumonia risk was reduced in both males and females, while the risk of paralysis was observed to be higher in males. Among the elderly aged over 65 in South Korea, concomitant vaccination of PPSV23 and influenza vaccine showed no higher risk for most events compared to sequential vaccination. Concomitant vaccination seems to have a protective effect against allergy reactions, neuritis, and pneumonia. However, given the limited data on its impact on allergies and neuritis, those with such histories might have been cautious about concomitant vaccination. Paralysis was divided into 3 subcategories and investigated separately. Among them, an increased risk was found specifically for paraplegia. While only a few paraplegia cases were reported in this study, few studies have investigated in the concomitant vaccination risk of PPSV23 and influenza vaccines causing paraplegia. Continued research and observation are essential for a full understanding of this vaccination approach. Let me turn to the values and the limitations of our study. This study is being among the first to utilize a large population-based data to assess the safety of concomitant administration of the PPSV23 and influenza vaccine. And for comprehensive safety assessment across different events, specific codes were established and defined for each event. Yet, the study has certain limitations. For example, Our reliance on claims data can potentially cause bias since we use diagnosis dates instead of onset dates. In addition, the immunization registry contains full records for NIP covered vaccine, not only partial information on self-paid vaccines. Consequently, we can't confirm the details of vaccines that are not recorded. Our findings suggest that concomitant vaccination of PPSV23 and the influenza vaccine might be safe and potentially more effective against pneumonia. It is recommendable for older adults, given that it not only reduces hospital visit, but also has the potential to boost PPSV23 coverage rates to be on par with influenza vaccinations. This brings me to the end of my presentation. Thank you for listening.
Any questions from the floor?
My name's Alekia, and the question is, you said it is recommended, but how is the currently the clinicians, are they using it or what are they recommending?
That's a good point. Generally, concomitant vaccination is safe, so it is recommended. However, it is not stated in guidelines, and there is no specific recommended interval. So after a medical evaluation, the vaccination schedule can be adjust based on the health conditions of recipients. Thank you.
Hi, Chris Bush, Aetion. Thank you. This was a very interesting presentation. I'm curious if you know the distribution from the time from the influenza vaccine to the pneumonia vaccine in your sequential cohort.
Oh, that's a good point. We just only influenza vaccine. Sorry. We only selected PPSV influenza vaccine prior to PPSV selected for the sequential vaccination. The influenza vaccine is recommended for annual administration, while the PPSV23 recommended once for those ages 65 and over. Since we set PPSV23 vaccination as the index date, so we selected the influenza vaccination prior to the PPSV23 as the sequential vaccination group.
Okay, all right, thank you.
Thank you.
Very interesting presentation, Cindy from Moderna. I have a question, not directly related to the presentation, but I'm wondering how the vaccination information is usually captured in South Korea. So for example, is it common to have a vaccination with flu in the workspace where the vaccination information is not captured in the database?
So we used linked database, registry, and claims data. So generally, we just claim data has no influenza vaccine, but we are linked database, so we can conduct this study.
So sorry if I'm allowed to ask a follow-up question. So for the immunization registry data, how complete it is if the person is vaccinated? And are you very confident that you're going to see a record in that registry?
Do you mean that it is
or in other words, if someone's vaccinated, it's possible that you will miss a record in the registry data?
I know that the NIP include NIP vaccination is all included in registry. So the self-financed vaccination is not sure about that, but and including NIP vaccination is usually included in registry.
I see. Okay, thank you.
Hi, very good, nice presentation. So I would like to ask did you examine the comparison of the concomitant vaccination group and only influenza vaccination group? So if you in the sequential vaccination group, so there is a risk period after the first influenza vaccination. So did you examine the risk in between the concomitant vaccination group and only influenza vaccination risk period?
First, we considered about the design.
Okay.
But our researchers discussed and reference paper the concomitant vaccination versus sequential vaccination is more we think more makes sense. So but I think yes, but I certainly consider it for the future.
You may already understand the risk of paralysis can be elevated just after the first mono influenza vaccination.
Sorry, please.
Maybe the risk of paralysis can be elevated because of the first only vaccination, influenza vaccination, not concomitant. It is possible.
Oh yes, yeah. Oh yes. Oh, we already found some research that
influenza vaccination do not give rise to the risk of paralysis.
Yes.
Okay.
Yes.
But I think for the more robust method to determine the risk, it is better to have such kind of risk index within your study.
Thank you.
Thank you very much. Thank you everyone for attending this session. We are a couple minutes over, so thanks for staying. I know it's been a long day, but lots of great content and really appreciate every speaker today for their great presentations. And I'm sure they're going to stick around for a few minutes in case anyone has any lingering questions.